welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EMED-PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
Today, I'll be presenting the comparative safety and efficacy on a hybrid IV Diltiazem protocol for acute rate control in the emergency department. So diving into a little bit of the background, of course, we know that AFib with RVR is an irregular rhythm, and it generally presents with a heart rate ranging from 100 to 150 beats per minute. And when we think about AFib RVR, of course, we want to think about the fact that it can lead to hemodynamic instability, a decreased perfusion, as well as tachycardia-induced cardiomyopathy, and even things like arterial thromboembolism and cerebral vascular events, and even death. When we think about AFib RVR, we think of our AFFIRM trial, which looked at rate versus rhythm control in an outpatient setting. And it did show that we saw with rate control, it impacts our quality of life as well as reducing our morbidity in our patients. If we look at our patients and they are presenting in a hemodynamic instability, we can use electrical cardioversion, and that's usually preferred for that acute control. When our AFib RVR patients, we think about our options for treating that AFib RVR. We usually think of Diltiazem and metoprolol, and those are our medications of choice for that use here in the ER. Looking into a little bit about the previous literature in AFib RVR and how it relates to this study specifically, looking at a retrospective study from 2016, where they looked at AFib RVR and they compared the standard dosing of 10 mg per kg, or 10 mgs compared to a weight-based dosing of 0.2 to 0.3 mgs per kg. And they looked at their primary outcomes were these heart rate less than 100 beats per minute, heart rate reduction greater than 20%, as well as spontaneous conversion to normal sinus rhythm at a time point of 15 minutes. They saw that they had similar percentages. So we had about 35% compared to 43% when we're looking at standard dosing compared to weight-based dosing. And in that heart rate less than 100 beats per minute, as well as with our heart rate reduction greater than 20%, we saw 60% compared to 68%. And then on our conversion of normal sinus rhythm, we saw 1.5 to 1.99 or 2%. And all three of these were not statistically significant. So overall, this retrospective review found that there was standard dosing of like a standard dose regimen of 10 milligrams was not inferior to a weight-based dosing, which is what we're normally used to. As well, something that stood out to me on previous literature that's pertinent to this study was looking at a retrospective study from 2018 that compared this IV bolus continuous infusion compared to this IV bolus, an oral immediate release tablet of Diltiazem in patients with AFib RVR. They looked at 111 patients, and their primary endpoint was looking at treatment failure at 4 hours, which they defined as like a heart rate greater than 110 beats per minute, as well as if the patient needed to switch therapy to either a different rate agent or an antiarrhythmic agent, or even if they had to switch from PO to IV, and the need for additional IV boluses. When they looked at treatment failure at 4 hours, they saw 46% in this bolus plus continuous infusion compared to 27% in the bolus plus this oral Diltiazem immediate release tablet. So we did have less treatment failure with this oral Diltiazem regimen, and so that was associated with the lower rates of treatment failure. When we look at our guidelines, we do have a 2014 guideline that was updated in 2023, and we can see that there's really been no change in our treatment of AFib with RVR. We still have a Class 1B recommendation that if our patients are hemodynamically stable, the IV administration of a beta blocker or a non-DHP CCB is recommended and preferred to help slow that ventricular rate in this acute setting in the ER. Of course, we want to be cognizant of our patients with decompensated heart failure or even an ejection fraction greater than 40%. When we look into a little bit of our PK/PD of these common agents, a big thing that stands out to me is our onset of action as well as our bioavailability. So of course, our Diltiazem immediate release tablet has a little bit slower onset of action of 30 to 60 minutes with a 40% bioavailability, but it has a similar half-life to our IV agents. And then comparatively, when we think about Diltiazem and verapamil, They are our non-DHP CCB, so they're going to inhibit those calcium ions from entering our selective channels during our depolarization phase, compared to our other common agent of metoprolol, which is a selective competitive beta blocker, and it's going to have a similar onset to our IV diltiazem, 5 to 20 minutes compared to 3 minutes, with a similar half-life, and of course, all of our IV agents have 100% bioavailability. Looking at this study, it was a single center retrospective cohort review from an 892-bed community hospital that receives about 200,000 ED visits per year. And it was conducted from January 1st of 2018 to May 31st of 2019. And the patients were screened in a reverse chronological order for inclusion. They included all adult patients greater than 18 years of age and that received at least one dose of IV diltiazem. And then when we look at their exclusion criteria, they excluded patients that had inadequate documentation, if the patient was diagnosed with an acute aortic dissection, or if the patient received another rate control medication prior to that IV diltiazem dose, or if the patient had a heart rate less than or equal to 110 beats per minute prior to that first diltiazem dose. They additionally evaluated 167 patients and included 140. When they actually went further, they did a pairwise propensity score matching, and they got a group of 53 patients in each group. When we look at our interventions, we can see that in our IV bolus plus our infusion group, they started off with a weight-based dose bolus of 0.25 mg per kg with a max dose of 25 milligrams. And they followed that, if needed, after 15 minutes with a repeat bolus with an increased weight-based dose of 0.35 milligrams with a max dose of 35 milligrams. And then once the patient received rate control, they followed it within a continuous infusion following the hospital protocol of titration, starting at 5 to 15 mg per hour. When we look at our IV bolus plus our oral diltiazem intervention group, these patients were started with a IV bolus of 10 milligrams that could get a repeat of 3 boluses, so a total number of doses up to 4 boluses of 10 milligrams every 15 minutes as needed to achieve acute rate control. And then they followed that by an oral immediate release diltiazem tablet of 60 milligrams. And their patients received that every 6 hours. They used an SPSS IBM Windows statistics program to help with their data analysis. And then, of course, they use that propensity score matching on a one-to-one basis to get those even groups. And they base that on the patient's age, sex, weight, as well as initial rhythm and initial heart rate. They used, for their statistical analysis, they used this two-tailed unpaired student t-test, as well as their chi-squared test and the Fisher's exact test. And they used a statistical p-value of less than 0.05. When we look at our baseline characteristics for the study, we can see that when we're looking at their age, their weight, as well as the sex, and even their initial heart rate and their blood pressure, the groups were pretty even, coming in at an average age of 74 with a weight around 86 kilograms. About half of the patients were female, and they had initial heart rates of about 140 beats per minute, and they were systolic blood pressure of 129 to 130 and a diastolic of 85. Both groups had a high percentage of patients initially presenting with atrial fibrillation, with a smaller percentage presenting an atrial flutter. We can see that there is a difference in the groups when it comes to their IV bolus dose. In milligrams, our IV bolus plus infusion group had a average dose of 28 milligrams that was required compared to our IV bolus plus our oral group, which required 22 milligrams. Looking at their primary outcome, it was the proportion of patients who had achieved rate control. And this, they defined it as a heart rate less than or equal to 110 beats per minute during that 4th hour from treatment initiation, without need for additional rate control and without need for additional IV diltiazem boluses during their maintenance phase, which they defined that maintenance phase as once the patient had already started the diltiazem continuous infusion, or once that it had received the first oral diltiazem dose. Looking at our primary outcome, we can see that it was not statistically significant, but our IV bolus plus our oral group had a 75.5% compared to 62.3% of patients that achieved that rate control within the 4 hours. Looking at secondary and safety outcomes, we can see that they looked at the proportion of patients with rate control after initiation at hours 1, 2, 3, and 4, as well as an average heart rate at 15-minute intervals throughout this course. And then safety outcomes, they looked at hypotension as well as bradycardia. They defined those as a systolic blood pressure less than 90 or a heart rate less than 60 beats per minute. When we look at this hour 1, 2, 3, and 4 comparatively, achieving that rate control, we can see that statistically we have statistical significance at hour 2 and hour 3 with a difference of 79% compared to 51% and 83% compared to 60% when we look at our IV bolus plus oral compared to our IV bolus plus continuous infusion. We still see a difference at hour 1 and hour 4, just less of a difference and of course not statistically significant. But overall, it seems that we had a greater percentage that achieved rate control in our IV bolus plus our oral group. When we look at our average heart rate at 15-minute intervals over that 4-hour duration, we can see a trend where our IV bolus plus our oral had a lower heart rate throughout that whole trend, except for one time point at 210 minutes. Looking at our safety outcomes, which I think are important to look at, when looking at bradycardia and hypotension, we can see that our IV bolus plus our oral group had lower rates, and they actually had 0 incidence of bradycardia compared to 4% in our IV bolus plus infusion, and then 2% of hypotension compared to 11%, which was not statistically significant, but it was very close comparatively in the bolus oral compared to the infusion. The authors concluded that there was no difference in acute rate control when using this hybrid IV oral diltiazem protocol compared to a traditional IV bolus plus standard continuous infusion strategy, but it is able to allow for hospital protocol development to help increase the flexibility of drug shortages or either medications, or if there was a shortage of patient bed spaces in specialized hospital units. When I look at this study, I think it has a couple of strengths and of course a couple of limitations. And so I think the strengths of the study is that it is a novel protocol and it has applicability to every ER. It's not the first study to look at this IV plus oral combination, but it is nice to take a look at it and it be retrospective. So we were able to see those real world results. When we look at the limitations of the study, there's the common limitations of it being a retrospective with a small sample size and no power calculation. And of course, our data abstractors were not blinded. But also a few extra things is the fact that they used averaged vital signs due to like an infrequency of documentation and the retrospective nature of this study. And so with all of our outcomes being based on vital signs, and then they had to average those, I think that could affect those results, as well as that change in the IV bolus dosing strategy between the groups of like the weight-based dose compared to like a fixed 10 milligram dose. And so I think that actually is a limitation because it adds 2 confounders or 2 variables to this study, as well as the fact that they didn't, in the baseline characteristics, there was no indication of like severity of disease and how we could compare the 2 groups in that way as well. When I look at the study and how we can maybe apply it in practice, of course, it's a newer approach into the treatment of AFib RVR, and it further expands on the previous literature that we have for the use of oral options for these patients, as well as adding that flexibility in treatment with similar outcomes and safety profiles. Even though they were not statistically significant, there is some difference in the safety profiles that maybe could see in practice more often. And then it may also allow for the ability to possibly discharge our patients quicker or even get them admitted quicker to help decrease costs to our patients as well as costs to our hospitals and decrease their length of stay in the ED. These are my references, and do you guys have any questions for me?
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the emergency medicine PRN.